with lots of white dots called drusen as compared to a normal. Okay, we don't want to reset the computer, no thank you. When he quantified the levels of iron in the RPE in 10 postmortem eyes compared to normals, he found that the levels were higher based on the pearl stain in the AMD RPE compared to the normals, and higher in Bruch's membrane in the AMD compared to the normals. Now, how does that iron get there? Why does it accumulate? So we've postulated that there's a mechanism that we call the cellular iron sequestration response, or scissor. We like acronyms. So in the scissor, cells perceive that there's a bacterial infection, and they try to suck up all the iron and to keep it away from the bacteria which otherwise need it to grow. And this is good in the context of a bacterial infection. But in the context of chronic inflammation, this same mechanism gets activated, and that is harmful. That leads to excess iron getting taken up into the cells and causing oxidative stress and damage. So this just shows this cycle of chronic inflammation, secretion of pro-inflammatory cytokines that activate this scissor response, upregulating iron importers, downregulating iron exporters. And then the cells fill up with iron, there's more oxidative stress, and they're damaged and potentially die. So this is a clinical example of what iron can do. If it gets on the cornea, as Dr. Zheng knows, it'll form a rust ring and damage the cornea. If it gets into the eye, intraocular, it can actually cause pigmentation of the iris. So this patient has heterochromia, 2 different colored irises, because the iron has promoted melanogenesis in the patient's right iris, right eye. In the retina, this is exquisitely damaging. So we see here bone spicules, similar to what it looks like in retinitis pigmentosa, and also macular atrophy. We've also created a mouse model of photoreceptor damage by iron. So here we've injected this eye with iron into the vitreous and waited 24 hours. Then we cryosectioned the eye and did a tunnel stain. The tunnel looks green like this, and it's telling us that the photoreceptors are exquisitely sensitive to the iron. They're all dying, but the other cells of the retina are not. And this is the control eye that was not injected with iron. You just see the blue DAPI-stained nuclei indicating that the cells are alive. So why is iron so toxic? Well, it reacts with hydrogen peroxide, which is ubiquitous. In the Fenton reaction, it's important, it's the Fe2+ form, or ferric form, that's the most toxic that can do this reaction, producing hydroxyl radical, which is the most damaging of the free radicals. It will immediately react with and oxidize DNA, proteins, or lipids. And this is exemplified in a hereditary disease called aceruloplasminemia. So here, patients lack ceruloplasmin, and ceruloplasmin's function is to oxidize iron from its dangerous ferrous form to its safer ferric form. So you can imagine that in the absence of ceruloplasmin, there would be more ferric iron causing this Fenton reaction. And these patients typically have a retinopathy. This patient in his 40s had this maculopathy that resembles AMD. And in his 50s, he died, and he donated his eyes, and we see histologically there are drusen, hypertrophic RPE, and RPE atrophy. Now this begs the question, how about a very common hereditary disease called hereditary hemochromatosis? Do these patients who have high iron levels in their blood also have an increased risk of retinal disease? Well, in this case, a patient who had AMD with RPE cells draped over the top of these drusen had lots of iron in the drusen. It's seen in the pearl stain. And there have been a number of cases of hereditary hemochromatosis with associated retinopathies, like bullseye maculopathies. But this doesn't happen in everybody with hereditary hemochromatosis. And so the question is, why not? So in one case, in Oregon, the physicians seeing the patient consulted with me. I asked them to check the serum ceruloplasmin to see if maybe low serum ceruloplasmin might contribute. So if there's high blood iron and low serum ceruloplasmin, then that iron would be in a more toxic ferric form. And they checked it, and sure enough, it was low in this patient. We then created a mouse model to test this hypothesis. Brandon Anderson, a graduate student in the lab, did this. And these are fundus photos taken by our resident expert, Brent Bell. Thank you, Brent. And here we see abnormal autofluorescence in the retina in the mouse that has hereditary hemochromatosis. But when we add a knockout of ceruloplasmin, you can see that this becomes much accelerated and much more widespread. And these are sections illustrating what the autofluorescence represents. Here, in just the hereditary hemochromatosis model, we see autofluorescent hypertrophic RPE cells. And here, with the knockout of ceruloplasmin, they're much larger, more damaged. And interestingly, half normal levels of ceruloplasmin also accelerate this disease. So we don't need to completely knock it out. And that mimics more what happens in patients who have low, not zero, ceruloplasmin levels. Okay, so how can we prevent this oxidation-induced retinal damage? Well, to understand that, we need to know what's damaged. And DHA is a culprit because DHA, docosahexaenoic acid, is the most abundant polyunsaturated fatty acid in photoreceptors, and it's very easily oxidized. DHA is like omega-3 fatty acid fish oil. Okay, and iron-induced lipid peroxidation, which is now called ferroptosis, a trendy name for a form of cell death that involves, well, exactly this process, may initiate AMD. So the evidence for that is that we've known for a long time from the age-related eye disease study that antioxidants reduce the risk of progression of AMD. Also, Joe Hollyfield has shown that DHA oxidation is present in postmortem AMD retinas. And also he showed in a mouse model that oxidized DHA could simulate features of AMD. Now again, DHA is susceptible to damage because it's very easily oxidized. This is a schematic of it where oxidants are modifying the DHA, oxidizing it. And then once one molecule gets oxidized, that can initiate a chain reaction, a lipid peroxidation chain reaction that goes all the way down the membrane, oxidizes 100 or 1,000 DHAs, and alters their structure like this. Also, when DHA is oxidized, it forms toxic products like CEP, carboxyethylpyrrole, and these have been detected in drusen and also by this dot blot in RPE cells in lipofuscin. So how do we prevent this? Well, here's DHA, the structure of it, and this schematic shows that it's reacting with ferrous 2+ iron to produce these toxic products like CEP. But if DHA is modified so that the non-radioactive isotope of hydrogen, deuterium, is substituted for hydrogen, then it's much harder to oxidize the DHA, and yet it still functions normally. Giving this to mice in their diets does not cause any problems with their viability, their behavior, their vision, the structure of their retinas. However, it's protective. So here's an experiment where we gave oral deuterated DHA in the diet of mice for 4 weeks, and then we injected iron into the vitreous and waited a week, and then gave the mice to Brent, who imaged them. And we also had a control group with a diet that was otherwise identical to the deuterated DHA diet, except that the DHA was not deuterated. So here's what the retina looks like with the not deuterated diet, lots of hyperautofluorescence, loss of photoreceptors seen on the outer nuclear layer thinning. And here with the DHA, deuterated DHA diet, we were shocked the retina looks normal, totally protective. Functionally, by ERG, compared to the control diet, the deuterated DHA was also protective for all of the waveforms. This is, there's a dose response. So this is control diet, and then with increasing duration of DHA feeding, we see less and less abnormal autofluorescence as we move toward increasing duration. Not only does deuterated DHA protect against iron injection, but it protects in another model that Elena Wojciechowski has been developing. In this model, Elena has knocked out an antioxidant called GPX4, glutathione peroxidase 4, specifically in the RPE. So this causes oxidative stress in the RPE and simulates ferroptosis. And when she feeds these mice, well, normal diet, they get this speckled autofluorescence and thinning of the photoreceptor outer nuclear layer. But when she feeds them deuterated DHA, they're completely protected. We also want to test this in a model of geographic atrophy, which is an advanced form of dry macular degeneration. This is a patient retina in the past showing an area of dead retinal pigment epithelial cells and photoreceptors that are dark on this autofluorescence image. And then later, 18 months later, you see that this area has expanded. This is the natural history of geographic atrophy. We wanted to create a mouse model of this to test the deuterated DHA. So Brandon Anderson injected a chemical oxidant called sodium iodate and then observed just fortuitously that in certain mice with a certain dose, he gets an area of atrophy that then expands over time. So we're now going to use this model, treating the mice only after they've developed the initial area of atrophy to see if it can, the deuterated DHA can prevent the expansion of the atrophy. So in conclusion, macular degeneration retinas have elevated iron levels. The iron is highly retinotoxic, especially in the ferrous form. Ceruloplasmin protects the retina by keeping iron in the ferric form. So low ceruloplasmin might be a factor that contributes to retinal disease. And oral deuterated DHA protects mouse photoreceptors and RPE against oxidative stress. And we're hopeful that we can move this into a clinical trial soon for retinal diseases that involve oxidative stress, which is most of them. I'd like to thank the members of my lab. These are the current members. They are very supportive. And many of them have posters, as I mentioned. This is also, a lot of people have come through the lab and trained and are now doing wonderful things in academic ophthalmology. And this is the financial support. Thank you very much.